Systemic lupus erythematosus is a disease that can affect persons of all ages and ethnic groups and both sexes, but more than 90% of new patients presenting with SLE are women in the childbearing years. SLE is a disease that affects multiple organ systems. Lupus nephritis is evident histologically in most patients. It is evident clinically in 50 to 60% of patients with lupus. Treatment of renal involvement in systemic lupus can significantly improve renal outcome. Lupus nephritis generally arises within 5 years of the diagnosis. Lupus nephritis can be divided into 6 subclassifications depicted in the following slides. Class 1 is minimal mesangial lupus nephritis. Abnormalities are detected by electron microscopy. Urinalysis is normal. Class 2, depicted in this slide, is mesangial proliferative lupus nephritis. Microscopic hematuria with or without proteinuria may be seen. Nephrosis, hypertension, and acute kidney injury are not common. Class 3 is focal proliferative lupus nephritis. Less than 50% of the glomeruli are involved. The involvement can be segmental or global in the glomeruli. The involvement can be active or chronic. Hematuria and proteinuria are present with or without nephrosis, hypertension, and elevated creatinine. Class 4 is diffuse proliferative lupus nephritis. This is the most severe and most common type. More than 50% of glomeruli are involved. Glomerular lesions can be segmental or global, active or chronic. Hematuria and proteinuria are present. Nephrosis, hypertension, elevated creatinine is often present. Class 5 is membranous lupus nephritis. Glomerular capillary walls are diffusely thickened segmentally or globally. This stage presents with nephrotic syndrome. Patients may also have microscopic hematuria and hypertension. Thrombotic complications may also be present. Class 6 is advanced sclerosis lupus nephritis. It is an end-stage manifestation of the disease. Global sclerosis involving more than 90% of glomeruli is present. This manifestation of the disease is characterized by slowly progressive kidney dysfunction. This manifestation also has a relatively bland urinalysis. Patients with clinical evidence of active, previously untreated lupus nephritis should have a renal biopsy to classify the disease. All patients with lupus nephritis should receive background therapy with hydroxychloroquine unless contraindicated. Glucocorticoids plus either cyclophosphamide IV or mycophenolate mofetil orally should be administered in patients with Class 3 or Class 4 disease. Patients with Class 1 or Class 2 nephritis do not require immunosuppressive therapy. Angiotensin converting enzyme inhibitors or angiotensin receptor blockers should be administered in proteinuric patients if the proteinuria reaches or exceeds 0.5 grams per day. Blood pressure should be maintained at or below 130/80. Patients with class 5 lupus nephritis are generally treated with prednisone for 1 to 3 months, followed by tapering for 1 to 2 years if response occurs. If no response occurs, the drug is discontinued. Immunosuppressive drugs are generally not used unless renal function worsens or a proliferative component is present on the biopsy. There are investigational therapies which are sometimes used in lupus nephritis.